good morning or afternoon, depending upon where you're joining us from. We are presenting on responding to abuse in later life, the role of forensic nurses. I'm Marty Washington. I'm the Abuse in Later Life Program Coordinator with the National Clearinghouse on Abuse in Later Life, or NCALL. And today I'm joined by Dr. Kathleen Timpson. And Kathy, will you introduce yourself?
Good morning, everyone. Thank you so much for allowing me to have this opportunity. I've been an RN for about 46 years. I've worked in hospitals, long-term care, and in home care. And I specialized very early in my career in wound management. And as a result of that, I had my first experience with elder abuse in 1983, with a patient who presented with 9 very severe pressure ulcers. Subsequent to that, I practiced in the hospital and had a private practice. But in the early 2000s, I was asked to review a case for an attorney against a nursing home that had 22 individuals who were victims of elder abuse. And that really started my trajectory from wound management in a clinical sense to a forensic nursing perspective that I'm very happy to share with you today.
Thank you. I'd like to pause before we get started and thank the OVW, or the Office on Violence Against Women, for funding this presentation. I also want to remind you that any of the findings or conclusions or thoughts that are expressed today are those of the author and don't necessarily reflect the views of the Office on Violence Against Women or the Department of Justice. Anna, will you walk us through some housekeeping?
Of course. Hi, everyone. Big welcome to you all. We have a large group joining us today, which is wonderful. I see some people are even sharing a Zoom screen from the comfort of your offices. So welcome. We're just going to cover some housekeeping items before we get started with our presentation. You all are very familiar with these by now. We've all spent now many years on Zoom, so none of this is new. Please make sure that you're muted if you're not speaking, just so we limit the amount of feedback that we're getting as we're walking through these slides. Feel free to use the chat function at the bottom ribbon on your screen if you want to participate. We do have over 60 folks on this call, so that's going to be the best way to engage today. If you do want to share out at any point, we will be able to take questions at the end, as well as there's a raise hand function on Zoom if you would like to verbally ask your question instead of typing. But I will be monitoring the chat throughout our time today. In addition to using that space, make sure that your Zoom square reflects the name that you would like to be referred to as. I'm not seeing any iPhones or iPads, which is great. But if you are wanting to engage with us today, please use the name that you prefer. Again, raise your hand if you have a question or comment. That's also in the bottom ribbon on your Zoom screen. We won't have breakout rooms this afternoon, so no worries about that. And of course, if you have any technical issues, can't hear, can't see, etc., please feel free to contact me. My email's on the screen, but the best way to reach me during this time is privately messaging me in the chat. I'll be here with you all today throughout the session. So if you have any questions, please direct message me. So welcome, everyone. We're happy to have you. I'm going to turn it back over to our wonderful presenters.
Thanks, Anna. Today, we're going to focus on understanding the role a forensic nurse can play in responding to older adults who have experienced violence. Also, how to engage them in our coordinated response. We also want to talk about special considerations when a abuse victim is older, and look at some domestic violence, sexual assault response models. So this is what we're going to focus on today. Before we get going, let's just talk about, make sure we're all on the same page as far as what we're talking about when we say abuse in later life. Abuse in later life is that segment of elder abuse that focuses specifically on cases where the abuse is perpetrated by someone with an ongoing relationship with them, like their spouse or partner or family member, etc. Sexual abuse and stalking by an offender, whether they're known or unknown to the person, is also included in this definition. What's not included is other types of abuse committed by strangers or sweetheart scams or self-neglect. NCAL's definition of abuse in later life intentionally calls attention to that nexus between domestic violence, sexual assault, and elder abuse. So while statutory definitions of elder abuse vary depending upon your jurisdiction or location, et cetera, we use the Elder Justice Roadmap definition when we talk about elder abuse. This definition includes different forms of abuse, including physical, sexual, psychological, neglect, abandonment, and financial exploitation. Elder abuse can happen in any setting, but it focuses on the relationship being one where there's an expectation of trust or the person is being targeted simply because of their age or their disability. Elder abuse is more prevalent than we know, and one study that we looked at found that at least 1 in 10 people that live in the community, older adults, experience some form of abuse. I want to just put a caveat in here. This study was done over the telephone. So it included individuals who have a telephone and were able to answer it. So what's not included in this study is individuals who maybe could not answer the phone or don't have one or didn't have the capacity to answer the questions, et cetera. So those people are not included in this study. It also didn't account for older adults who live in a facility or other kind of a living situation. So while it's a staggering number, it's likely a very low estimate. Another study found really confirms this, that elder abuse is commonly not identified. For every one case that comes to light of financial exploitation, there's another 24. See, it's severely underreported. We're becoming age 65 and older every day. The population is booming, 65,000 a day. And so the demographic that it has really changing the face of our country. And the rights of older adults who may be at risk really aren't identified, or they may be suspected but not reported, et cetera. So that's really plays into this number of unreported cases. And also consider that our research shows that older adults that are abused visit the emergency room 4 times more than other people of the same age. And so you can see why it's particularly important that we learn about forensic nurses and we partner with them to better meet the needs of older adults. Older adults are at particularly high risk of mistreatment because they may be, if they have disabilities, they may be perceived as helpless or really vulnerable and easy pickings. The vulnerability of individuals who are older and disabled can be compounded. Nearly half of all victims have a physical impairment, and about 1/3 of them have a mental impairment. But be cautious when you're looking at these statistics, because sometimes ageism clouds people's mind and they think they may perceive older people as being vulnerable. We have 50-year-olds who are infirm and mobility issues, and we have 90-year-olds running marathons. It really varies so much as far as not only physical, but also mental capacity. Prevalence rates vary by types of abuse across studies, but it's pretty consistent when we look at elder abuse that it impacts all genders. But it consistently shows that a large proportion involve females who are perpetrated by their spouse. And this slide really highlights how physical abuse is very often intimate partner violence. You look at this 57% by a partner, but when you add in a child or a grandchild or other family members, 76% of physical mistreatment is perpetrated by a family member. There's few studies about the prevalence of sexual assault in later life. But what we found in the few studies that we have, that older adults will more commonly report that their abuser was their spouse or their partner if they're living in the community. When we find that they live in a facility, it's kind of half and half between staff and other residents. I know when I was a social worker in a long-term care facility in New Mexico, we would have daily reports of abuse by other residents. So I know it's very common to see this happening. I just want to add here before we go on that our population is growing. The older population is growing, and abuse in later life occurs in the home, in facilities, in the community, etc. It's really important to understand the role that different agencies play in supporting survivors of abuse in later life. Today, we're going to focus on one of those roles, and that's of forensic nursing and how they provide care, and also how we can collaborate with them to more fully meet the needs of older adults. And so with that, I'm going to turn it over to Kathy.
Good morning again. So I want to share with you some of the work I did in working on my doctoral degree back in about 7 years ago. And in that, my focus was elder abuse. And I really wanted to focus on better identification by healthcare providers relative to identifying patients presenting for a common condition or complaint to an emergency department. So I worked across country and up into and included Canada. I had one hospital in Canada, emergency department, and then I had 4 across the United States representing each region of the country. And what I did is identify what their barriers and obstacles to identification of these victims might be. And I looked at a lot of the hospital's data in terms of emergency room encounters, and was able to validate the fact that many of these patients were presenting for care multiple times during a 1-year period, and nothing was showing up until late in the trajectory of their condition, and their oppression of being abused were things readily identified when it was quite apparent by their very obvious signs and symptoms on presentation that they were being abused. So I looked at victim perspectives, and I also looked at healthcare provider perspectives, and then I'll give you the forensic nursing perspective. But we know that victims very often don't see themselves as victims, number one. And if they do see themselves as victims, they share with us a great deal of shame. There is a terrible stigma about admitting that you're vulnerable enough, you're dependent on other people, and you're aging. And this whole ageism perspective, and that is the bias against the elderly, really comes full circle when you talk to victims. They feel that there is no one listening to their complaints or taking them serious. So their voice is not really being heard very well. They also have a great deal of fear relative to losing whatever level of independence they still have on board. And again, it's really difficult to identify and admit that you're a victim and you're caught in this situation, and you really somewhat lose hope, and you have very limited places to turn to for resources and for help. Also, victims also complained about the fact that when they were being seen in healthcare provider situations, or working with social workers or counselors, that the encounter was very time limited, and they They weren't able to express everything that they had concerns about. And they were kind of, again, not given an opportunity and ample time to verbalize and to get their problems out. But again, more inclusive research is needed among various populations, because this population was significantly white population, lower to middle class, and straight individuals. So we have a lot of opportunity to look at other populations from a victim perspective to better understand their barriers and identification to disclosing an abusive situation. Next slide, please. So in the clinical realm, it becomes a bit more complicated. The age-related changes really are very predictive in terms of creating obstacles to being identified as a victim of elder abuse. And by that, I mean that a lot of people will say, oh, the complaints that an elder person brings up are related to the fact that they're just old. And in the case I'm going to illustrate in a little bit, that will come full circle to show you that, oh, it's an old person and that's why this person had urinary incontinence, or in many cases, the cognitive changes are related to, oh, they're just old and that's why they don't remember, or their memory is cloudy. And subsequent to that, there are physiologic changes that take place in individuals that really relate to the fact that these individuals have a lot of stressors and cognitive dissonance because of the stressors and the cortisol, the stress hormones that elevate in the body that create some of these changes. Again, healthcare providers are pretty much ageist, and I'll have to admit that I have a degree of ageism. When I first started this work, I took the ageism survey to identify that, and sure enough, I think we all have to understand and acknowledge that we do have a bit of ageism or bias on many levels. So that plays a role in healthcare, in that prescriptions are written or treatment protocols are written, and subsequently the patient doesn't get a voice or a choice in a matter, when in fact, there's many treatments that are really not good for long-term management of a person over the age of 65. But not giving a patient an opportunity to learn about the risks and the benefits of that treatment or medication or protocol is missing, and it's all related to ageism and some of the protections that healthcare providers have taken shielded over the years with standing up against those criticisms, but that's come full force. We also have the impact of medication effects that often mimic problems that a patient might have, but in many cases, in identifying clinical signs of elder abuse, whether it's bruising, whether it's any kind of bleeding, whether it's maybe deformities or contractures, can also be looked at as, oh, that's a side effect of the medication, when in fact, it's not the case. There are other indicators that we as forensic nurses look to kind of tease out and differentiate those effects. And certainly comorbidities, whether it's diabetes, cardiovascular heart disease, whether it's vascular disease, whether it's arthritis, those types of comorbid conditions also confuse the identification of elder abuse. And then certainly in an emergency setting, we have the prioritization of care, because we have a time-limited opportunity to see a patient, treat them for what they're presenting with, do the screening exams that are implicated for that particular age population, and subsequently that time frame really gets compressed. So we don't have time to necessarily really start to look at some of the things that we need to look at. But again, it all starts with being aware of how do we differentiate age-related changes, comorbidities, and the true signs of clinically identifying elder abuse. Slide, please.
Before we move off of obstacles, there's a couple of comments in the chat that I just want to share. Great comments. Sarah added, there are added barriers when victims are residing in long-term care settings. They may fear retaliation from staff or other residents. This is certainly true if the perpetrator is an in-home caregiver as well. And then Barbara shared, she sometimes accompanies a patient to a doctor's appointment to help advocate for them if they're not able to do so or don't have anyone. So I just wanted to throw that in. Those are definite obstacles that we see. Now we'll move to the perspective of the forensic nurse.
So when we look at forensic nursing as a specialty, we are registered nurses that have advanced education and training in a competency-based model. And our first and foremost foundation is to nursing science. So we're nurses at best. And in nursing, our first primary role is always to advocate for a patient. Now, when you get into the forensic realm, we also have advanced education and training in forensic science. So that includes evidence collection, evidence differentiation, DNA and an understanding of DNA and transfer, storage, life longevity. We look at any kind of laboratory and toxicity types of reports and the forensic processing of that. Evidence collection is in our domain because we're responsible for doing that at the point of encounter when a victim does identify and present. And then also we advance our education and training in the legal parameters. So we adhere to regulatory guidance as well as legal parameters as it relates to our interface with a patient relative to evidence collection, the preservation of that evidence, the chain of custody, understanding the process involved in an investigation and in laboratory validation and the laboratory sciences. And then certainly from a legal side, we do provide not only witness testimony as fact witness, but also as expert witnesses. Next slide, please. So who's a forensic nurse? Well, we're registered nurses, which means that we have at a minimum a bachelor's degree in nursing, and most of us have advanced degrees, either a master's degree or doctoral degrees. And again, we've received specialized education and training in the specialty of forensics, which I just talked about, the 3 domains. We provide especially services and care to persons who are experiencing either acute, where it's just happened, or perhaps long-term health consequences that are associated with the victimization or with trauma and violence, which we know that looking at the ACE study, which was a childhood study, we know that the effects of trauma and violence on a child affects the entire lifetime trajectory of that individual. So in the case of our victims of elder abuse and the cyclical violence that occurs, many of these victims have had long-term exposure to trauma and violence, which we know today, given the science and the DNA analysis, is that these victims have a change within their cellular structure based on their long-term exposure to stressors and to trauma. We also provide consultations for civil and criminal proceedings regarding nursing practice, regarding potentially evidentiary exams, injury identification, and opinions that correlate to findings that really gild the lily in terms of differentiating abuse from a clinical condition or age-related change. Slide, please. So why is forensic nursing so important to disseminating to you all today? And that's because we're very interprofessionally, focused in terms of we are part of a team of people, because it takes a village today, regardless of what I think any of us do. It takes more than us to manage a case in this situation. So what we do is we identify with our patient any types of indications by doing basically a head-to-toe exam, whereby we are identifying any kind of evidence that might exist. We collect that evidence, we label it and preserve all that evidence during the clinical care that's received at an emergency department, or while the patient's in the hospital, or if they're in a clinic visit. We also provide holistic trauma-informed care to the patient. And trauma-informed care is critical to our interface with the patient. And this is a process. I'll just say this as a caveat. Healthcare has not always been trauma-informed, and not all healthcare organizations or the industry of healthcare services itself is trauma-informed, but there is a huge movement towards that. And by trauma-informed care, I mean we regard the person who's the victim of some sort of a crime, whether it's sexual assault, interpersonal violence, neglect, physical assault, gun violence, elder or child abuse, trafficking, or whatever other instance that that person may have suffered trauma through. We provide care that respects them as an individual, and we don't re-traumatize by having 4 people ask them the same question, so they have to relive their trauma. Rather, we seek to identify and appropriately and efficiently collect information and evidence in that case, and then we document all of that in a record. We serve as also, as I said before, fact or expert witness by giving testimony in different types of trials and proceedings. Slide, please. So forensic nurses see violence as a public health crisis, and I think we can probably all agree on that, because it's increasing in our communities, not only in the United States domestically, but globally as well. And that really is creating healthcare problems, not only in the short term, but in a chronic long-term perspective. And the presence of a forensic nurse is that we help victims through whatever level they are in the process of their experience. And we have many intervention programs focused on prevention, as well as the intervention once a person has experienced violence and trauma. And there's various kinds of trauma, but some of the more typical types of trauma that we're commonly seeing, and I looked at kind of corroborating this with some hospital data that comes from a government source, HCUP. And so we're seeing more in the emergency room of strangulation, physical abuse, and sexual abuse. And in these 3 very common areas, if you look at this, and I have a number of cases to kind of justify this, these are 3 that fall under the radar because they're very difficult to clinically identify. And so it takes a lot of extra training to really be able to tease out when any of these are perpetrated. Next slide, please.
I have a question in the chat. Are you tracking polyvictimization? Are you concerned with emotional abuse in hospital settings?
Oh, absolutely. And that's a huge, thank you for that question. Emotional abuse is the kind of the pathway that all of the abuse gets started with. And it unfortunately then just escalates, but that emotional, psychological abuse really never goes away. And hospitals are the worst. And I didn't allude to what I do now in my primary job, and I am an associate professor of nursing at the School of Nursing at University of Nevada, Las Vegas. And I've been in education for about 14 years. And I will say that the trajectory of how we are teaching our student nurses, and I work with our School of Medicine as well and our School of Social Work, we really work as an interprofessional team, and we do a lot of team training to address the way that we communicate with and provide care to patients. And we teach our students a trauma-informed process of and caring attitudes in the work that we do. That's part of our competencies. It's not just about educating, healthcare providers anymore on the facts of how to manage XYZ condition and the interventions, but rather our behaviors and our attitudes as well. And that's a huge area for improvement. And when I talk about the Academy of Forensic Nursing in a few minutes, we also have this cause where we are really addressing that interface through our behaviors and our practices. So thank you for that question. Next slide, please. So forensic nurses practice in a plethora of places, and I'm not going to go through each of these bulleted items, but there's multiple access points in various locations within your reach, I'm sure. However, if you don't have an access point for a forensic nurse, there are a lot in hospitals, hospital emergency rooms, but there are emergency rooms that don't, and hospitals that don't have forensic nurses. But there are opportunities that you can reach out and find a resource if you should need that by going to the Academy of Forensic Nursing's website, which I've included a link here at the bottom of the PowerPoint, in that you can go there and we can help you identify and find a qualified forensic nurse to meet the needs that you have, maybe at a more local or regional level. Next slide, please. So when we talk about our nursing role and responsibility, primarily when a patient presents for care to a forensic nurse in an emergency department, one of the things, or at a hospital, one of the first things it's our job to do, because we can't assume every patient that comes through the door is a victim of a crime or trauma, is that we provide a clinical assessment on the patient. So it might be during this clinical assessment where we do a head-to-toe look at the patient visually, but we're also examining various parameters from a neurologic perspective to a cardiovascular perspective to an orthopedic perspective, etc., urologic, colorectal, GI. So we're looking at the patient not only visually, but we're also looking at symptoms of their systems, their various body systems. And specifically, when we start to look at individuals, we want to really look at, through that exam, taking a good medical history and identifying their general state of health. And we do that by not only looking at and examining the patient, but we look at doing data diving in the electronic health record, because this is where, in my work with my 5 hospitals across the country, I really helped them to identify that this is a vital source that should be included in their evidence collection, because this is where you pick up the admission trends on those individuals who are victims of abuse, who are presenting for care 3 and 4 times the rate that a normal, or I won't say normal, but another individual of their same age is not presenting for care. So this is where you look to identify those kinds of trends, and are the complaints the same? That really can give you a good trajectory on your patient status. We also really look at their medication regimen, because again, a lot of medicines have side effects, and those side effects can really be explained as side effects when in fact we need to do some laboratory testing to see if the patient is really getting the medication, or is the patient getting medication at a higher quantity or volume that is being ordered? Are they being overdosed on certain drugs? Cardiac drugs, water pills, all of those types of medications are all subject to abuse. Of course, when we do a skin and wound assessment, this is where you really can focus in on any type of skin alteration. Maybe it's bruising, maybe it's petechiae or some blood that is exposed on their face, which is a symptom of strangulation, their face or their neck or around their eyes. Maybe there's bruising that wasn't identified because it was not maybe on a surface that was exposed outside of their hospital gown. Maybe they have wounds that we're not seeing. Maybe there's burn marks, or maybe there's beating marks. We also really look at nutrition and hydration, because, and I'm going to pull those two together because they're very closely associated. And in some work I did with about 578 patient records of cases of abuse that I've worked on, I went back and did an analysis on the trends and changes that these patients experienced. And what I found is that in 97% of the cases of abuse that I saw, now full disclosure, 100% of these patients had wounds of a catastrophic nature. So it was really no surprise to me that their nutritional status was altered. But what did surprise me was that the nutritional status was the first clinical indicator of a change in the person's state of health. And that change occurred, their dietary intake changed 10 months before they got a wound, 10 months before they fell, 10 months before they started appearing in an emergency room for recurrent types of assessments for various ailments, whether that's fecal incontinence, urinary tract infections. It all went back to looking at their nutritional intake. Now, the nutritional intake and their hydration status is closely aligned with their degree of social engagement, which was also very interesting to find. The social engagement piece came out of a study that I worked on at St. Louis University back in 2007 with the primary investigator, Dr. Pam Cascione. And we looked at social engagement, visual and auditory hallucinations and alterations of individuals who were in long-term care facilities. We had about 300 patients in that study. And what we found is that patients' nutritional status changed based on the fact that they had visual disturbances or they had changes, whether it was cataracts, macular degen, retinopathies, as well as they had a loss of hearing. And when they couldn't go or didn't go to the dining hall anymore because they didn't want to be answering questions that really weren't asked, or they couldn't hear the question properly, or they couldn't see their place setting, which just needed some contrast enhancement, those patients withdrew socially, then they stopped eating and they stopped drinking, and they developed wounds as a result, and their weights had significantly changed. And so you'll see that in these patients with abuse. And that was, I will say that was an astounding point of that timeline of 10 months before big problems happened. The nutritional intervention really needed to be addressed. And to the audience's points about long-term care, this is where it was predominantly happening. And of course, when you get weak and you're not eating and you're not drinking properly, or you have wounds, your mobility and your activity declines significantly, which then also exacerbates and prevents social engagement and pursuit of some healthy lifestyles wherever the person is residing. Next slide, please. So the forensics nursing role and responsibility is based in nursing forensic science and the law, but our foundations were really to evaluate our practice clinically and partition it forensically, which is sometimes hard to do when you're a clinical provider. However, One of the things we have to do from a forensic science perspective, and because of evidence, and these are victims of crime, and data we're collecting or evidence we're collecting is related to the perpetration of a crime and its evidence, that information is separate and aside in the electronic health record from clinical documentation. So there should be a partition of a forensic file separate from a clinical file. And we know that in many institutions today that isn't happening, that a lot of the documentation is still going into the clinical file, which then prohibits the access that a patient might have to a really comprehensive investigation when only part of the evidence is showing up in evidence collection and in the chain of custody process, as opposed to having to have the clinical file has to be subpoenaed in many cases to get access to it. And it's some work I have been doing with the U.S. Attorney's Office on evidence collection and tracking. We found that a lot of times police departments, law enforcement, are not allowing the forensic nurse to collect the evidence, all of it, or they are collecting evidence and they're taking pictures of patients, but the pictures of the actual injuries that the nurse takes are never admitted into evidence. So this is problematic. So there is a huge thrust in our forensic education to educate our forensic providers on the fact that there needs to be a partition of the evidence files and the forensic exams from the clinical EHR, electronic health record. We do document extensively about our findings, whether that's injuries, whether it's interview process, or the description of evidence. It's all part of our domain of responsibility. In the evidence collection process, we collect all the evidence, we label it, we preserve it, and we enter it into documentation, and then we provide that handling and handoff to law enforcement to pick it up. We also provide forensic photo documentation, which we have extensive training and education on, and that should all be admitted through this chain of custody process. Next slide, please. So we work with a patient at the time of the encounter. We might consult on a case that's being investigated. I know the work that I do is as an expert witness, so I don't work in a hospital emergency room. I do consulting for some hospitals when they have a need to differentiate, again, abuse signs and symptoms and conditions against comorbidities and age-related changes. But basically, we also consult on cases to help identify areas where we may have, there may be additional evidence that hasn't been identified. An example I'll give you is there was a case of a patient who died in a nursing home, and it was described as he accidentally hung himself in the privacy drape in the room, when in fact, when I was reviewing the case for an attorney for the daughter, the situation was the ligature mark of the hanging evidence on his neck was not consistent with a hanging. It was consistent with being strangled. And subsequently, we communicated that there might be more victims in this nursing home. We were able to identify 2 additional victims in the nursing home that were victims of non-fatal strangulation by the same means, because they had the same ligature marks on their neck. They just didn't die from the strangulation. So we can provide that kind of support for investigations. And then we also provide expert witnessing, as I said, outside of being a fact witness that you had taken care of a patient. Next slide, please. So these are some of the competencies, documenting patient histories. We have extensive training in physical assessment, and differentiation against clinical exams that we do from a medical perspective, forensic documentation and photography, maybe taking videos of a certain type of injury that we're identifying and trying to validate, evidentiary exams, injury identification. You'll see in a case that I'm going to discuss in a second, a little bit about injury identification, treatment recommendations, healthcare referrals and follow-up, and then testifying in case proceedings. Next slide. So I'm going to go to the Academy of Forensic Nursing. We're an organization of forensic nurses, obviously, and we're a global organization. Our platform and our purpose and mission is to provide care to people whose lives has been affected by trauma of some sort. And we do that through scholarship or research, educating our membership, and then providing services. Next slide. We've all got a variety of experiences in our cadre of nurses that came together in 2018. We sat around a table at Ending Violence Against Women in Chicago, and we figured out we had over 500 years of experience in nursing and over 240 years of experience in forensic nursing practice. And we came together to take up Virginia Lynch's vision. Virginia Lynch was the mother of forensic nursing. In 1993, the specialty of forensic nursing was born. And in 2018, we developed a non-for-profit, and our name is the Academy of Forensic Nursing, and it was born. Today, we have grown just unbelievably from our meager beginnings in 2018. We are now an international organization, and we have nurses from 23 countries around the world, and including the United States and Canada. Well, again, we deliver compassionate care in our practice of forensics, using science to provide a voice by identifying safe medical treatment and justice to patients who experience trauma in all its form, by being able to identify, collect, and preserve any type of evidence that supports a thorough and comprehensive investigation into the allegations that were made. Next slide, please. So what we do is we work with the patient, and every patient's body is the crime scene, and it's our primary responsibility, again, to advocate for the patient. And in advocating, we really have to sometimes educate the patient on the importance of preserving evidence that can be present on their body. And everyone plays a vital role in facilitating that evidence preservation while interacting with the patients. Exams are very invasive. I'm not going to tell anybody they're not invasive, because they are. And they're very time consuming. The average case can take 3 to 5 hours to do an exam on a patient. So that's a forensic nurse with our patient that we're collecting evidence on. We take medical care is the priority when a patient presents, but once they're cleared medically, then we can pursue collection of evidence. So let me give you an example. If a patient that presents, states that they have ejaculate on their hands, but they have a head wound that's bleeding. What we'll do is employ measures to preserve that evidence on their hands while we're attending to the bleeding and identifying the extent of the damage or the injury that is causing the bleeding. Will stabilize the site and will care for the bleeding wound prior to collecting the evidence. So though in those cases, we preserve the biologic and trace evidence in any way that we can, but still tend and provide care clinically as our priority. Next slide, please. So I'm going to talk a little bit about John's story. Next slide, please. So John is a 73-year-old semi-retired widowed gentleman living with his son and his family. And he was working a part-time job, and he started by becoming anxious at work, and he was demonstrating some handshaking and changes to his speech pattern, and he began to stutter. So he sought out going to his primary care provider's appointment for a medical workup. He was slightly confused in the evenings, and he started to have situations of urinary and fecal incontinence. And over a period of 4 months, he exhibited a 30-pound involuntary weight loss. Now, this case is being used to demonstrate a multi-agency response: hidden abuse, the perspectives of John, our victim, and the use of a forensic nurse during the emergency room encounter and throughout the process, as well as in supporting and advocating for the resources to support John's recovery and his resilience while providing safety and trauma-informed care. Next slide. So at his PCP visit, he was diagnosed with depression with anxiety disorder. He was treated with some antidepressants and anti-anxiety meds. He was on Flomax, which is a prostate drug. And Flomax causes men to retain urine, which can also create urinary tract infections. And it can also cause incontinence because you have what we call overflow incontinence. So that's kind of where they were thinking his urinary incontinence was coming from. And sometimes if you have urinary incontinence, you can also have fecal incontinence because the bowel can't empty properly. So they ordered additional tests for a GI workup to also rule out cancer with his fecal incontinence symptom. But all of his workup showed no findings of any pathology to explain some of his problems. Next slide. So fast forward a couple of months down the line, Division of Children and Family Services was called to visit the home by the school because they were concerned about the welfare of John's grandchildren. During the interview with John in the home, the caseworker noticed extensive bruising to John's arm and his shoulder. It was in the summer when they came. So I incorporated a picture of his bruising to his upper body. So it was quite extensive. And he also had a wrap to his wrist. Next slide. So John, during an examination was called upon at a community advocacy center. This did not warrant going to the emergency room, but he was examined and interviewed by a forensic nurse examiner. And John was pretty relieved to be in the space because of the way that the forensic nurse really was interfacing with him, made him feel comfortable, wouldn't allow anyone else in the room while she was examining him, even though the daughter-in-law wanted to be there and was fairly overly protective and overbearing. So she was asked to leave the room, as is our protocol, to get the patient alone, to make them comfortable and feel safe. So once that really transpired, the patient, John, disclosed that he had been emotionally abused by his daughter-in-law for many, many months. And in addition, he was also being physically assaulted by his daughter-in-law. So the nurse began to look at the bruised area. And can you go back a slide? I'm sorry to kind of jump back and forth. Yeah. So I don't know if you could see it from where you're looking at it or the acuity of the picture, but if you look at that, there's very much of a pattern to the bruising across his chest, his left chest. So you can advance it back to where we were. So that bruise was actually the shape of an item that the caseworker had remembered seeing in the home. Next slide. But because of the community response and the caseworker and the forensic nurse debriefing each other after the exam and the interview, it was decided that it was best to remove John from the home and get him placed in an assisted living center for 55 in a 55 plus community. His speech returned to normal. His anxiety resolved once he was safely discharged and placed. He was not on any medications and his appetite improved. His incontinence also resolved. He gained his weight back over time, and he was really thriving in his new environment. And I think the turning point of this was the debrief and the sharing of information from the perspective of the caseworker, because once the forensic nurse showed the picture of the bruised area and the pattern, she said, there's a plastic toy dinosaur that was by his chair that is exactly the pattern of that injury. So the daughter-in-law had been beating him with that toy, the grandchild's toy, for a period of time. And he, as a result, had some post-traumatic stress response and had all of those signs and symptoms, many of which are very common and very difficult to differentiate and tease out against comorbidities or age-related changes. Next slide.
I just want to jump in here and say we're almost at the top of the hour, but we do have some important information to share. If you're able to stick around with us for a bit longer, we would love that. We do have some questions in the chat, but I do understand if you have other obligations at the top of the hour.
So the physical impact of trauma can affect many organ systems of the body, and subsequently these conditions that are up on the screen really need to be investigated and examined by a trained and qualified healthcare provider and a forensic nurse. Next slide. So I think one of the things I just really want to impart is that we have many, many ways that people respond to trauma and violence. And there's no one normal or right way that people respond. So all of these aspects listed here on this slide really are to be investigated and considered. And again, there is no normal response to trauma and violence. Next slide. Most physical wounds heal in time, but with elder abuse, it does and can lead to an early death. It does harm the patient, the person physically and psychologically. It destroys social and family ties, and it can cause devastating financial loss and much, much more. Next slide. There is a cycle of abuse and neglect. We talked a bit about polyvictimization. This does occur. There's a fear that their health conditions will again result in a loss of independence. This came through in those victim interviews that I did. And there certainly is a case to be made for hopelessness that elders do experience once they have been included in this cycle of violence. Next slide. Some of the principles of trauma-informed care and response listed here. There is a link here for you to go to SAMHSA's website. This gives you guidelines and a toolkit and guidance for creating a trauma-informed environment or organization for you to pursue to help to change the trajectory of how we operate in whatever space that we're working in. Next slide. We also at the Academy of Forensic Nursing have an elder readiness checklist. This is available from us directly. You can go to our website and contact us to get a free copy of that. This is what we would recommend that you use with your clients in preparation for time during depositions or trial or exhaustive types of interview processes. Next slide. Again, you can collaborate with us at the Academy of Forensic Nursing. We are open to interprofessional collaborations and learn additionally about the signs of elder abuse and how to differ them from the normal aging process. Next slide.
Thank you so much, Kathy. As you see, forensic nurses have this unique view of abuse in later life, not only based on their services, but the different access points that Kathy had mentioned, where they come into contact with older adults. So they have this unique perspective that would really help in a collaborative environment. As was mentioned before, we can't do it all when you're working with a patient or a client or a survivor. It really takes different lens to look at it from different perspectives so you can really meet their full needs. Their informal and formal collaborations are important. They both play a role. If you were to have an informal collaboration with a forensic nurse, it might look like brainstorming about what trends they're seeing or what gaps in available services they can identify. And you can see from the plethora of situations Kathy described that forensic nurses work in, that they really are in a great position to have their pulse on what's happening with older adults. And so bringing them into your collaborative efforts would definitely be great. Grab a cup of coffee with a forensic nurse. There's also formal collaborations, multidisciplinary teams that a forensic nurse may serve on, or a coordinated community response team. For those of you who are not familiar with that term, what we're talking about is working on response to abuse in later life from a systemic or a macro level. A multidisciplinary team will actually staff individual cases and talk about individual situations. But a coordinated community response team looks at what the overall response is, what different agencies that communicate and refer back and forth, how they communicate with each other, what are their protocols, what are their limitations and guidelines to their work. So bringing a forensic nurse in you would get a great perspective. But also, the forensic nurses can gain something from being involved in a coordinated community response, because they may become more familiar with the limitations or the protocols, et cetera, of your agency. So it's great to have that give and take. What does this collaboration look like? It could be sharing resources. Kathy did talk about one thing when you were talking, Kathy, about trying not to re-victimize the person with repeat interviews, trying to really look at that. Is there a way you can share resources so you don't have to keep re-interviewing that person? Is there something that can happen with intake forms that you might be able to gather information for each other? Exchanging information. It's so important that through collaboration, you learn how information flows between agencies and how that might work to enhance what you're doing or support the person that you're working with. True collaboration creates accessible, culturally responsive, and trauma-informed services and resources. And what you're doing is you're moving from a fractured response to the person where everybody has a piece of helping them to a more intentional, coordinated one. And it's very powerful when you can do that. We do have some questions in the chat that I want to, and I hope that the person who asked it is still here. These go to you, Kathy. How prevalent are abuse cases identified in the hospitals?
So I'm not sure which way to answer the question. If you're talking about abuse that's perpetrated in the hospital, I don't have data on that. That probably is a good thing to look at. In terms of the data, what it shows as cases that are identified, it looks to be about 12 to 14% when you look at the same stats that you presented, Marty, of 1, to 24%. So, and what's identified in a hospital is usually pretty severe. So, but the data is not well defined, truthfully. And I think it goes back to what you mentioned early on in your presentation about the fact that there's a lot of barriers and obstacles to self-disclosing and certainly to identification that we really need to work on. That's why I really wanted to work on this project. So there's still a lot of work that needs to be done so we can have better data to really understand the problem.
And there is almost no data on abuse in later life. So most of the statistics we talk about are about elder abuse because there's a little more of a study. But abuse in later life, when we talk about individuals age 50 and older, they fall between everybody's categories or experiences, et cetera. And so it's really difficult to get that data. There's another question for you. Have you given any attention to the human trafficking of older adults, and what have you found? Because I know the answer is yes.
Yeah. So my other area of interest in forensics is elder abuse, and I was part of a big organization back in St. Louis when I lived there a few years ago. Through Washington University, we had the Human Trafficking Collaborative Network, and the trafficking of elders is a problem. And where I'm working with a writing group on a manuscript at the present time, where we're looking at the benefit trafficking that's going on with elders. And I have a colleague in Canada who's going to be collaborating on another research project that looks at the trafficking of elders because they had an elder that was sex trafficked in Canada. And I, back in the 90s, had a significant case of elder trafficking in a nursing home. They were using the elders who were in pretty immobilized situations as points of prostitution for drug exchange. So it's a problem, and thankfully the courts had intervened, and that's why I was in this nursing home when I stumbled across this problem. But again, it's a problem that's not really well researched and certainly not written about enough. But we've got a series of 6 manuscripts coming out in the next probably year and a half. So more to come. And if you're interested, please reach out to me. And if you want to collaborate on something, because our group is always interested in collaborators.
I just want to add here that you all received this slide deck, and it has our email on there. So you'll know how to reach Dr. Timpson. And Jackie had her hand up. So let me just say, if you're able to stay with us, please do. Otherwise, thank you so much for joining us. Jackie, did you want to jump in?
Yeah, I'm the person, Dr. Timpson, who asked that question about trafficking. We actually just had a case, and I'm on the Human Trafficking Coalition.
Oh, I emailed you.
You did?
I did, because Marty gave me your name. I emailed you, I don't know, a couple weeks ago.
Oh, yes, you were interested. Yeah, she asked me if I would be, but you know what? I didn't get your email.
Really?
I don't think so. I'll look again. I don't think so.
Well, can you put your email in the chat and I'll
Yes.
Do
I
that,
would love
Jackie,
to
because
talk with you about this.
yeah, because we're redoing a textbook, and my one chapter is on elder abuse, and I wanted to interview you for that chapter because I can't add more authors now, but there's some other work that I'd like to talk to you about.
Okay,
Yeah,
Jackie's
if
email
you don't
is
hear
coming.
back from me, I didn't get it for some reason. I'll give you my cell number too,
Okay, why don't you do that?
just in case.
Let me see.
Are there any other questions?
Yeah, sorry, we're getting kind of personal here. Well, thank you so much for your interest in the work and commitment to continuing the work. It was very much of an honor for me to be here today and to work with you all.
And we have something else in the chat. Would you be
Oh.
willing to present at an APS MDT?
Absolutely.
Okay, so April and Chris, you in the slide deck, you'll see Dr. Timpson's email. So give her
I
an
can put it
email.
in the chat if that helps. I don't know. I'll stick it in here real quick.
Any other questions?
Marty, thank you for all that you have done with me and for me. You've been very patient with me.
Okay, well, it was a pleasure, and thank you so much for your bringing your expertise to the table today. I am sure that that the collaboration level will go up now that everyone understands exactly what forensic nurses have to bring to the table. So, Anna, did you want to talk about the Survey Monkey? Or
Yes. All right. So I dropped in the chat, it should have come up for you all, a brief evaluation just about the content and our wonderful presenters today. Please take a second to fill that out. I promise it takes less than a minute, and it's really helpful for us to get that feedback. But other than that, if there's no more questions, thank you all so much for your time. Thank you to both of our presenters, and I hope you have a good rest of your week.